Good afternoon. We are continuing the Section 59 of the Medical Schemes Act inquiry. The next presentation is from JMH Holdings, which stands for Joint Medical Holdings. Who is going to be doing the presentation?
It's myself, Vishnu Rampatab.
Rampatab.
Yeah.
Are you doctor or Mr.?
Mr.
Mr. Are you the only one who's going to be speaking?
I've got Sunny Govender, our CFO, also representing.
Mr. Govender. All right, good. So, Mr. Rampatab, let me take your oath. Are you happy with the oath or an affirmation?
Happy with that.
Happy?
Yeah.
Will you say after me, I, and your name?
I, Vishnu Rampatab,
swear that the evidence that I shall give
swear that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
and
nothing but the truth.
and nothing but the truth.
If so, please raise your right hand and say, so help me God.
So help me God.
Thank you. Mr. Govender, are you happy with the oath?
Yes, I am.
All right, so will you say after me, I and your name?
I, Sunny Govender,
Swear that the evidence that I shall give
swear that the evidence that I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Please raise your right hand and say, so help me God.
So help me God.
Thank you. So, Mr. Rampatab, let's start with you. We've got this document,
Yeah.
and we have another one, which is this, which have just been handed up, the
Correct.
affidavit.
Yeah.
So, and we have your full submission, including the litigation
Correct.
matter that you were involved in. So you can take it that we are familiar with some of the content here,
Okay.
although not here and not here.
That's fine.
So you can take us through in whatever structure you've decided.
Okay. What I've done, Chair, is I've prepared a presentation that talks through the affidavit itself, and I'll talk through the presentation now. So just to introduce myself, Vishnu Rampatab, I'm the Group General Manager. Sunny Govender is our Chief Financial Officer. With us, we do have Dr. Tabete and Dr. Tesi Reddy, who are the two directors on our board and have been involved in this investigation from the time it started. In terms of some background, Joint Medical Holdings Proprietary Limited owns 4 acute hospitals in the Durban and Isipingo precinct. Many of the group's facilities were established in the early 1980s by a small group of black doctors who...
Sorry, I just see on this piece of paper actually that I forgot to just get your counsel to put themselves on record, even though they have no speaking rights.
Thank you, Mr. Chair. My name is Shane Dayal. I'm from the Durban and the Johannesburg Bar. I'm instructed in this matter by Maharaj attorneys.
Thank you, Mr. Dayal. Do you have a junior? No.
No, unfortunately not.
Thank you, Chair. I'm Manoj Maharaj from Maharaj Attorneys, the instructing attorneys in this matter.
Thank you, Mr. Maharaj.
Yeah. So just to go on, many of the group's facilities were established in the early 1980s by a small group of black doctors who, because of apartheid laws in place at the time, had no place to consult, admit and manage their patients who were predominantly from the low and middle income black communities and not as an incentive for wealth creation. The patient profile of the group remains the position to date. The Doctor Shareholding Company comprises approximately 500 shareholders represented by individuals, companies and trusts, almost 100% of which are black owned. Just some background in terms of there's 2 matters that we have been engaging with in terms of the inquiry with MedScheme, and the 2 matters were Ascot and City Hospital. I'll talk through Ascot Park Hospital first.
Sorry, Mr. Rampatab, will you expand on what you've just said in the first slide about the genesis of JMH Holdings and why it is you have entities in particular locations and
Okay,
so on? I mean,
I
will you be dealing with that in any further detail? I'm not asking for a lengthy presentation, but just a little bit more.
Okay, so the hospitals, as I mentioned, were started in the early 1980s. Doctors from the predominantly black African and Indian communities, and those doctors practice in the Durban area. They set up their rooms in those areas. At the time, there were no rooms for them. They had to build their own rooms and set up practice. These hospitals were then built after their rooms were established around where they set up their rooms. And then they slowly evolved their practice from there.
What is an acute hospital?
Acute hospital is where patients are admitted for ongoing stay as opposed to a day hospital where they're admitted for just a day procedure.
That's distinguishable from a day hospital.
Correct.
Now, one of the reasons I think my colleague is asking for you to expand on this topic is that you will know that our terms of reference include the question of racial profiling.
Yeah.
And so when we have a hospital group that is predominantly black, servicing predominantly black patients, that's the context in which the question arises, if it's relevant at all to what you are going to tell us.
I think I will be talking through the slides in terms of why we believe it's relevant. So on the Ascot Hospital Park matter, we were approached in June 2018 by McDonald Marabo, representing MedScheme Forensics. He at the time advised that he was representing a number of schemes under MedScheme's administration, and that they were requested to carry out an investigation in terms of the admission patterns of doctors at some of the hospitals, and particularly at Ascot Park with Noah Group. And they had some concerns regarding the admission patterns, and that they were going to place the accounts, payments on hold with effect from that date. And that was followed by a formal letter of the 14th of June. A meeting was then facilitated between Mr. Marabo from the forensics unit and the JMH team on the 4th and 5th of July at Ascot Park Hospital. The forensic team, without providing any case-specific details of the allegations, reiterated their concerns around admission patterns of some of the doctors at the hospital. Particularly on the meeting on the 4th of July, Mr. Marabo raised concerns around the admission process in the hospital, as their investigation had shown that many instances where patients are admitted into the hospital, but they could not pick up a record of the treating doctor having consulted the patient prior to the admission. They were concerned that patients were simply coming to the facility and being admitted without having been consulted by a doctor. I found that rather strange and explained to him that patients are only admitted into the facility after being referred from the admitting doctor, who would generally issue an admitting note to the hospital. I then facilitated an interview with our Ascot Park Hospital reception supervisor, who elaborated and confirmed the admission process. A few inpatient files were presented for him to see the evidence. At the time, we had requested that he provide details of the files and the queries so that management could call up the files for those specific patients and present the evidence of the admitting doctor's referral. No further details were provided at the time. At the meeting on the 4th of July, Mr. Marabo also expressed concerns around the admission patterns of one of the doctors practicing at Ascot. I advised that I could unfortunately not comment on the admission patterns of the doctor, but would be glad to facilitate a meeting with him so they could engage him with their concerns. I accordingly facilitated a meeting with the doctor. Unfortunately, they chose not to discuss with me in presence, and they had a private meeting with him. After the close of the meeting, I again reiterated the need for him to present the details of his concerns so that we could investigate and present feedback. No information was presented at the time.
Recollection of your evidence, certainly in the affidavit, was that you had a chat with this fellow on the 14th of June.
Correct.
He gave you one story. Shortly thereafter, he sent you a letter, which you say that the letter differed from the contents of the conversation, because in the conversation, the allegation pertained to doctors, but in the letter, the allegation pertained to the hospital itself. But I see now you've moved on to July without tying it up with the issue of the letter that was sent in June immediately.
So in the letter, he had mentioned that he had concerns regarding the admission patterns of the doctors, right? But when we met with him at the meeting, he also expressed concerns around the admission patterns of the hospital itself. You know, the doctors refer patients to the hospital. So he was concerned that patients were being admitted into the hospital without any prior consent.
But can you go to page 155 of your affidavit, the original affidavit, paragraph 47 of the affidavit? The affidavit that you used to bring the urgent application against MedScheme. So if you go to paragraph 47, So you say shortly after speaking with me, Marabo transmitted a letter to me by email that was addressed to Ascot Park, a copy of which is annexed. And then you say its contents were materially different from his telephonic conversation with me because it made mention of investigations into Ascot Park Hospital rather than into admitting doctors.
Just get to that. See, if you look at his letter was regarding the admissions at the hospital.
Yes.
But yet in the discussions we had with him, he mentioned also admission patterns of doctors.
I understand it. I mean, I just want the line that says the letter differed from the conversation because in the letter he's referring to the hospital rather than the doctors. I mean, as to, in the affidavit you say that you are being misled about what is going on from
Correct.
the get-go.
Yeah.
So I just want to know if, to make sure that I get that story right, was your testimony a couple of minutes ago was that actually there wasn't too much of a discrepancy between what was said and what was in the letter.
Yeah, as I said, in the letter he mentioned that they had concerns around the facility, but when we spoke to him, he also mentioned that he had issues with the doctor that was admitting at the facility. But remember, the doctors are independent; they're not employed by the hospital. Okay. We then wrote to Mr. Marabo just to follow up on the matter because we hadn't received any correspondence from him. And then on the 19th of July, he then sent us a letter placing us in terms of Section 59.
Yes, but there had been a prior meeting, I mean, before that. You met with them on the 4th of July.
Correct, yeah.
And in that meeting, he did tell you that this is the likely outcome.
So at that meeting, he hadn't shared any details, specific details. He just made general comments. He advised that he had some concerns, and he had already, by that time, he had already placed the accounts on hold.
That's one of the things I couldn't work out here because when he phoned you on the 14th of July, my understanding from your affidavit was that already by that time, MedScheme had decided that payments were being suspended.
That's correct.
Yeah. But the actual formal notification came on the 19th of July.
Correct. So he sent us a letter on the 14th telling us that, if you look at the letter of the 14th, he says that, let's make sure. Yeah, he says, as indicated by principles of corporate governance, we decided to hold facilities payments pending resolution of the matter. That's on the letter of the 14th. Okay. So on the 19th, we then received the letter, and I think on the 19th, there were two key areas that he had identified as concerns. One was hospital length of stay, where he indicated that hospital accounts indicating costs of scheduled medication during patients' admissions without any record of consultations by either the family practitioner and or the specialist. And then he says that there were healthcare provider visits only occurring on the third day of admission, and patients were being admitted for 3 days or longer without any procedure having been scheduled or no record of consults by the healthcare provider prior to those days. The hospital had also been admitting psychiatric patients to Ascot Park Hospital despite not having a psychiatric license. So if I can just elaborate on this, what he mentioned was that they had looked at the MedScheme records, and in looking at the MedScheme records, they could not find claims from the consultants, being the GPs and the specialists, for consult for the GP prior to the patient coming to the hospital or for the specialist for the first day of admission. And that's the basis on which they then set up the investigation. I will show, I think I have in the presentation as well, just explained the background in some of the investigation and presentations.
Were the payments actually suspended I know they told you that they were being suspended.
It was.
Immediately on the 14th of June.
So the first payment that was due to us, I think on the 28th of June, 2 weeks after they sent us a letter, and with immediate effect they had suspended. Because I think in the correspondence as well, you see there's a letter that I had sent to him to clarify the position, and he then re-clarified to say the payments were actually placed on hold.
And now, I mean, what this was my understanding of this affidavit is this is the first time you ever became aware that there was any query
That's correct.
of any discrepancy, whether it's hospital-based or doctor-based.
At no time prior to that did they raise it to us. On the issue of high care beds, the concern was that the hospital had...
Sorry, Mr. Rampetab, you were not in here, but in your initial affidavit in the court case, you said that one of the anomalies that he picked up was the differences between your admission patterns or between admission patterns at this hospital and other hospitals. What other hospitals was he referring to?
So I think they obviously looked at other hospitals. Ascot Park does not have an outpatient facility. It has patients coming to Ascot Park that are referred from specialists. An outpatient facility where you'd have patients off the street go into an outpatient facility for an emergency, and they would then be referred from the outpatient facility to the hospital for admission. At Ascot Park, the doctors have consulting rooms. Patients see them in the consulting rooms, and from the consulting room, they would then be referred into the hospital.
When he investigates, he meets with you on my understanding, on the 4th of July. You say to him, I can't answer on behalf of unidentified doctors. He says, I can give you the names, but he gives you a name of one doctor.
Correct. And then that's the doctor that we attempted to meet on the day, and he decided to obviously have a private meeting with that doctor. And I think just to elaborate as well, for that particular doctor, what I had done was I facilitated to have that doctor's inpatient files available so they could actually look at the files and look at the referrals from the doctor and admission patterns. I think the query he had that was that patients would rock up into the hospital without a referral from the doctor and get admitted. So we wanted to show him the evidence of the admitting doctor's referral note, because that's the only basis we admit into the hospital. But he decided not to look at the files.
This was at the meeting
At the
where you
meeting,
offered
yeah.
that information.
Correct, yeah.
And he declined to...
To look at the files. I think on the point of the other hospitals, he's obviously comparing us to the other hospitals in the area, whether it was City Hospital, the other hospitals that they work with being in Tubani, and the other hospitals in Durban. Okay. Just the next point they raised was high care
What
beds.
other hospitals are in a similar sort of position as Ascot?
Okay, in the Durban precinct, we have the hospitals that belong to JMH. It's City Hospital, Durrock Hospital, and then up the road from us, we have Ntibeni Hospital, Parklands Hospital, St. Augustine's, the Lenmed Group, New Shifa, Westville, Maruchcombe. There's quite a few in that precinct. In terms of the other hospitals that are there, I think there's the hospitals that are belonging to the independent groups, being Lenmed, which is Nishifa, eThekwini, and the hospitals on the hill are the predominantly listed companies, being Life Healthcare and Netcare.
Hospitals on the hill would be Ntibeni, Parklands, and
Correct,
St.
yeah,
Aug's.
yeah. Okay. The second matter they raised at Ascot was the concern around high care beds. They had on the investigation found that on occasion the hospital had admitted patients to high care in excess of the actual licensed beds that were granted. Some background on this is that the hospital has one high care bed, license for one high care bed and 3 ICU beds. And on occasion, you would find that if the high care bed is already occupied and there's a need for a second high care bed, the hospital would then admit that second high care patient into an ICU bed because it's in the same unit. And the medical aid scheme would then be charged the rate of the high care tariff. From the hospital side, we obviously believe that this is in the interest of patient care and we're not compromising patient care, and we're charging the scheme at the correct tariff, so we're not, the scheme is not at a loss in any particular way.
So the ICU bed is more expensive than the high care.
Correct, yeah, that's correct. And And then, based on the limited information, if you look at the letter that they had circulated, there were no specifics provided. We provided a high-level response to them, and which is marked in the court papers FA9. And you see on the submission, it was very high level, just spelling out based on the limited information that he had circulated to us. A schedule of listing the sample of cases was then sent to us by MedScheme on the 1st of August, and then management then engaged in a series of communications with MedSchemes to provide explanations on a case-by-case basis. And copies of the correspondence have been attached to the papers FA9 to FA14. In terms of the communication that we had sent to them, we had highlighted the fact that the information is being provided on a summary basis, and the length of stay and details of the admission, and particularly the fact that the admitting doctors make clinical assessments of patients and they are responsible for the admission, treatment plan, and length of stay, and that if they were unhappy with any queries, unhappy with any of the information provided, they should meet with those doctors so the doctors would clarify any further queries they had. And unfortunately, that did not happen. We then received a second letter from them, again on section 59.3, dated the 3rd of September.
Mr. Rampetab, the amount that was claimed, you
Yeah.
say was based on 20%
Of the admission,
of the admissions during the period
January
of
and
to May
May
2018.
yeah.
Why 20%?
So they, based on I think the cases they had audited, they just extrapolated 20%. They have never at any stage provided details or a listing to say that the claim of 3.9 million is made of this and this case, where we found fraudulent activity on part of the hospital. There was never ever any schedule provided. They just used the 20% as an arbitrary number and said this is what we believe is as being inappropriate admissions, and they used that number to quantify it.
You know, one of the reasons why this question, if you go to page 223, it says a letter from you on the 30th of July
Yeah.
to MedScheme. See, the second paragraph says it is difficult to respond appropriately without being presented with the details of the specific cases upon which your findings have been based.
Yeah,
So we've got that.
I've got that, yes.
Now, you were never, in fact, given those details.
That's correct. I think if you look, that was only sent to us. The first letter that came to us was on the 19th, right?
Yes.
And then we wrote to them to ask them for the details. So the letter of the 30th is still at a stage where there were no specific details. It was a very general letter that we submitted.
Yeah, in fact, what happened is at 227, in response to that, this is what they gave you.
Correct.
An email where they said, attached here with find extracts from your claim data as per your request. And then it says, with sampled examples of each issue raised from your correspondence, with understanding that your facility is actually primary source of information and we are secondary. So in other words, you know the allegations against you, why are you asking us?
So I think their point is that we obviously have the admission information, but they hadn't given us a schedule of which specific cases they were concerned around. So if they mention that we have a concern around case number 1275, we would be able to go to 1275 and understand what their query was. But at that stage, they had not circulated any details to us. It's only after this letter they had given us a sample of cases on those three categories that we were then able to go back and respond to them on a case-by-case basis in the letter that I had sent them later in August.
Because here they say, it thus follows that the attached could be verified against your facilities database. You just tell me, at this stage, this is now the 1st of August, they
Yeah.
had suspended you from the 28th of June anyway.
That's correct.
So you are not getting paid.
Exactly.
Yeah.
Exactly. Exactly.
But anyway, you've got the sample now, so you can go and check your primary data. And
Correct.
tell them whether they're right or wrong.
So the first time that information came to us, as I said, was on the 1st of August. Prior to that, there was no schedule provided.
Yes. But what, I mean, so what did you do with it? I mean, it's a schedule. It tells you no record of aftercare treatment, no record of aftercare treatment, no record of treating provider, but you've made claims. So at least on the face of it, it looks like it's fraudulent.
So I think that's the point I was trying to make, was that in the earlier statement is that for some reason they've looked at their records only. Now, unfortunately, and I think this I'll talk to you in my slide later as well, is that a lot of patients, when they're consulted by a GP, if they have no funds available, outpatient funds available, that GP will charge that patient cash. So that claim never gets submitted to the medical aid. And the medical aid obviously is not going to see it as their part of their claim data to say that this patient was consulted as an outpatient. And secondly, the same with the specialist. If a patient is seen by a specialist in his rooms and the guy doesn't have benefits available, the same principle will apply, and the scheme will unfortunately not see that transaction where the patient was charged for that service. I met with Mr. Marabo in the first meeting when he sent the schedule to me on the 1st of July. I was up in Johannesburg for a meeting, and he asked whether he could meet with me. And at that meeting, I carried examples of cases where we had actually had the referral note from the referring GP to say that I consulted this patient beforehand and I referred this patient for admission. And he did not look at that document. And even if you look at my letter that I had submitted subsequently after he had sent the schedule to us, on a case-by-case basis, I had spelled out the incidences where those patients were consulted by the GP before they were seen in hospital and they were referred. So that letter that I had sent through, I was going to find the actual date.
24 August letter.
That's correct. I think that's the one, 24 August, where it actually spells out on a case-by-case basis. And if you look at it,
Before that letter,
yeah.
there had been a meeting between you and MedScheme on the 14th of August. When I say you, your company.
on the 10th. On the 10th. He sent us a letter on
Yes,
the 14th.
it was the 10th. Okay, I see. Because that is at 2:39.
Correct, yeah.
So, yes.
Yeah. So that's the day we had a quick meeting at OR Tambo Airport, and at that meeting I carried a sample of cases where, based on the schedule that he had sent us on the first, where we had done some preliminary investigations, and I showed him that we had contracted those doctors and they had actually seen those patients, and those patients had actually paid them cash for those consults. Now, unfortunately, he's basing his assumptions on the evidence that he's picked up on the MedScheme database that there was no proof of consult, there was no proof of payment for that consult. But that consult was obviously done as a private arrangement because the patient did not have limits available.
If we can just go to what he actually told you, because I have no doubt that will be the case of MedScheme at 2:39. So, high care beds. It says, in response to the point made in our letter of 19th July on this issue, we indicated that patients we referred to were actually housed in ICU as opposed to high care. And then it says, we still find such explanation to be unacceptable since that way of claim submission was anomalous and contrary to license limitations, let alone the fact that even ICU beds were not enough to accommodate such number of patients. And then they give you to the regulations. Now, one difficulty I had with this is that this is unrelated to the reason for the investigation.
Mm-hmm.
It flows only from your responses. And because the investigation was not based on the discrepancy between high care and ICU, it was based on something else.
Yeah. So if I can just elaborate on that point, it's in my presentation as well later, is that there are occasions, the hospital has 4 ICU beds. There are occasions in any hospital that you would find that you have an emergency that comes to either from an existing inpatient or from the outpatient department from a theater case where the patient is now complicated and was not planned to be admitted into that ward.
Yeah.
The hospital has an obligation to treat that patient. You can't now tell this patient, I don't have an ICU bed, I don't have a high care bed, I'm going to now send you out. That patient is already complicated, you need to manage that patient. So what hospitals generally do in those circumstances is that they have equipment at other facilities, they borrow equipment in order to facilitate treatment for those patients, and we accommodate those patients in the adjoining ward. And we've done that, and you'll see in my presentation that we've done that. All hospitals do that in emergencies.
And the second part that he made, which is in any event, you did not have enough ICU beds.
I think that's the point he was raising, because we would have gone over the license capacity
Yeah.
at that stage.
But what do you say to that?
So that's the point. We do acknowledge that, because when you have an emergency, you go beyond that. You can't now turn that patient away. If you full to capacity and you have a patient that comes out of theatre and is now requiring a bed, you can't transfer that patient to another facility because you're going to compromise that patient.
What's the relevance of whether you've breached the regulation to whether or not the scheme must settle the invoices?
I think from our side, the important part is we don't see that we've done anything wrong, because we've treated the patient. Now priority is providing patient care. If the scheme believes that we've done wrong, then they have to obviously prove that.
Yeah. And then the next thing they raise here, which again I just want to comment on, they say we advise that your facilities license, which is under 2 psychiatric admission, your facilities license is renewable on a yearly basis. We're therefore not willing to recognize such letter. That's when you gave them a letter saying this is our letter from the department.
So those were two different matters. So that was regarding the psychiatric license. So some background on the psychiatric license is that Ascot Park Hospital, let me just get to that slide, because
Anyway, look, we are now taking you off your
okay, yeah,
thing. So I think just take us according to the way you've prepared your presentation.
not a problem.
Sorry, Chair. Sorry, Chair. Used you to Mr. Rampart off, and now I just need to have a quick follow-up on that, because one of the things that interested me, but I'm not sure whether I'm understanding it correctly, is in that FA11, for example, the med scheme investigator refers you to the regulations regarding private hospitals and seems to be suggesting that you are acting unlawfully by charging for a high care bed when you have admitted into an ICU. That's what they're suggesting, that you're acting contrary to the regulations. I just want to know, what is the relevance of that? What is the interest of a medical scheme in regulating you in that respect?
Okay, so if I can answer that. So firstly, the tariff for high care is lower than ICU. The point I had made in my document, my response to him was that in the circumstances where the one high care bed is already occupied, we would use an ICU bed where the tariff is normally higher.
No, I get that, but there's no harm to the med scheme.
That's
there.
exactly the point. That's the point I tried to make in the scheme. I think the point he made was that there were circumstances where we had gone beyond the 4 beds and obviously accommodated those patients. But again, for us it was priority to provide care to the patient, and the patient was not compromised. I don't see what loss the scheme had in that circumstance. So just in terms of 245 of the bundle, page number 249, if you look at, accordingly we are of the view that there was no prejudice to medical scheme. We have highlighted that to them.
Yes, that's your response on the 24th.
Correct, yeah. So we have, I think in terms of the ICU as well, sorry, the other issue was the psychiatric beds issue.
Yes.
A point that they had raised was Ascot Park does not have a license for psychiatric beds. Psychiatric patients, as we know, require specialized facilities to treat them. I think most facilities admit patients on a voluntary basis, but even so, those facilities need to have certain special requirements for psychiatric facilities. And Ascot Park did not have those specific requirements. And the procedure was effectively is that if there were no beds available at City Hospital and the psychiatrist was wanting to admit a patient and Ascot Park did have beds, then we would make a request to the scheme. We were fully aware that Ascot Park did not have a license, and I'll present it to you a little later as well, and that on the motivation they would grant us consent for limited stay subject to that patient being transferred out at a later stage. So the scheme, we're fully aware of that information.
Yes, I just want to finalize this FA11 because it's got 2 further points I want to explore with you. So when it's LOS, what is LOS?
Length of stay.
Length of stay, yes. Now, that's the over-servicing complaint.
Correct, yeah.
Now, they say here, we advised and demonstrated to you through records of our system that such consults were never in our system. So remember, that's what they told you then, that there's no record of the consults.
Correct.
Yeah, that's what they told you in their letter of 19th of July.
Yeah.
Say for pathology and radiology claims, subsequent to our meeting, we became more worried and concerned about exactly some behavior by such healthcare practitioner, only on admission claims associated with your facility. To this end, our position hasn't changed and we stand by the contents of our letter. So does this mean that at that meeting of the 10th, you in fact failed to show that the allegations about length of stay were unsubstantiated?
So remember, this is post his initial letter of the first, his email of the first, at which stage we had not yet submitted our response. This is post, he sent us a letter, then I met him at the airport with some of the samples presenting the evidence available, and I think I alluded to the fact that unfortunately he's not going to pick up those consults where those patients paid cash.
Specific consults.
Where they paid cash, and he's again alluding to the fact on that point, despite my having mentioned to him that we had the evidence to say these patients were consulted, because I had actually personally spoken to those GPs that said, I saw this patient on such and such day, and that information is then presented in the subsequent correspondence that I had presented. So even before having seen the evidence, he has made a call that you haven't presented the evidence.
So you see, where he is going is the last paragraph. It says, as indicated before, we are a bit perturbed by the length of period that lapsed between our first interaction and now. Yet we respect your endeavor to satisfy yourself with highlighted issues before settlement could be reached. We really appreciate your cooperation thus far, but may we appeal for the matter to be expedited. So this thing is now moved from I want information to I want a settlement.
Correct. So if you look at it, I mean, the first time we got any schedule from them was literally the 1st of August. So from the 1st of August, I met him on the 10th of August at the airport with some information, and then he pushes to say we want settlement of the matter. And then within a few days thereafter, I had then submitted a detailed schedule on a case-by-case basis, trying to explain the information.
And you're going to come still to the 24th of August?
Yeah.
Okay. But at the meeting on the 10th of August,
Yeah.
where you attempted to address the concerns that were being raised,
Yeah.
was it at that point that he said he does not want to see the evidence of the admission, of the referral, doctor's referral? Was it at that point? Did you explain to him then that it was a cash-based?
I did show him a few to say this is, I spoke
Because he doesn't seem to reflect that in this letter.
That's exactly
that
it.
that is an explanation for why it's not in the system.
The unfortunate thing is, no matter what explanations we gave, they were not interested in any of the explanations. At the meeting, I said I've got samples. I actually carried the admission notes or the referral notes of those GPs that referred those patients to hospital for those days. And they said because they could not pick it up on the system, they did not see that as valid.
But were they concerned with the particular healthcare practitioner?
They didn't present that to me at that time.
So when they say exactly the same behavior by such healthcare practitioner, it's not a specific
Remember
doctor that they're referring.
the sample that they gave us were a few practitioners. It wasn't a specific.
Can you just explain why is the scheme unable, just for our understanding, unable to pick up outpatient consults?
So what happens is, well, firstly, Ascot doesn't have an outpatient facility. So these patients would normally go see a GP in the vicinity where they live, and that GP would then see them. Unfortunately, they don't have an outpatient benefit on the scheme. That practitioner would charge them cash. Now that transaction is not going to appear on any record of MedScheme. The only time it will appear if that patient has a medical savings and if the practitioner submits an account, the scheme will then pay that funds out of the medical savings benefit or the outpatient benefit. That's the only time it will come up on the MedScheme record. The fact that it did not appear doesn't mean it didn't happen. And in the evidence that I had circulated in the next letter, I specifically mentioned that this patient was seen by that GP on that specific date.
I mean, if you tell a scheme, I presume, if you say to a scheme, the reason you don't have the record is because it was outpatient, and the next logical thing you would expect is that they will go to that doctor and ask,
Exactly.
did you in fact see this patient?
Exactly.
Anyway, look, I try to stop us from directing your evidence. So you can take us back to where you were and then go through the way you prepared it.
So what I've done is, I think on the escort matter, I've just tried to highlight, I think, the key areas they had identified as reasons for the clawback. So I think the one was obviously the hospital length of stay, and this was specifically the med scheme forensics could not pick up charges for consultations by referring GP or the admitting specialist on their system for the initial referral or consult. I think it's the point we've been debating all the time, is that doctors may in their discussion, depending on the socio-economic circumstances of the patient, decide to charge a patient for outpatient consult. In some cases, they might do it free. In the sample of cases they had provided to us, many of the doctors had charged the patient cash, as I mentioned, and in some of the cases, the surgeon that they mentioned, he had treated those patients on a medical basis first, and then taken that patient to theatre on day 3 or 4. Now, from what I understand is, when patients are taken for surgical procedures, the surgeon is only allowed to charge for the surgical procedure as one charge. He's not allowed to charge for his consults thereafter or before. So this particular doctor had not charged for the medical consults, and that's why they didn't see it. In my documentation that I had submitted as well, I highlighted to say that he did see the patients, the evidence is there in the file, and the fact that he didn't charge for those consults doesn't necessarily mean he didn't consult those patients. The fact that MedScheme could not pick up evidence of payment of the consultation on their system does not mean that these consults did not occur or make the admission fraudulent. That's the point I was trying to make.
Yeah, I mean, that's the point at page 249 of your
Submission, correct, yeah.
Yeah, I mean, you went through each of those patients, explaining
That's correct, yeah.
when they were seen by which doctor, for how long, and for what.
That's correct.
And that was from your follow-up with the doctors involved. So you went and did the...
So what we did is we actually picked up the information from our patient files, and in some cases we actually called those doctors, the GPs in particular, to find out, when did you see this patient? What did we actually spoke to the specialist first and said, if we didn't have a letter on file from which GP that patient came, we then spoke to the specialist and said, who referred the patient to you? The specialist said, I was referred by a particular GP. We went back and spoke to the GP on what day did you consult, and we picked up that information. This is what we put to. And my view is this should actually have been should have been verified by MedScheme, because had they done that, they would have been able to verify the information. The second point that they had raised around Ascot Park was that patients...
Sorry, Mr. Rampaka, one just last thing. On the 10th of August,
Yeah.
did you and MedScheme discuss settlement?
No.
Or were you at that point
No.
saying that there's no basis whatsoever?
There was no basis. At the meeting of the 10th, I literally just, he mentioned that if you're in Johannesburg, if you have some time, please make yourself available to discuss some matters. So I was in Johannesburg for a meeting, so I said I will meet you. I carried those sample of cases, and I said, let's meet. And that's all I was there to present, the evidence of the sample that I had identified. It wasn't meant to be a detailed meeting. It was just from preliminary discussions.
But it wasn't
investigation.
discussion of settlement
No,
at that meeting?
no
of any
no
sort?
such thing. No such thing.
I mean, the one thing I'm sorry to take you back to this, you know, if you look at how, so if I'm a scheme, I'm conducting an investigation, and I say, look, this looks, you know, problematic, I'll give you a sample.
Yeah.
You then go and do the exercise. You phone the doctors, you visit the doctors, you give me the full data. And now I go to page 263, and I'm looking for the answer to what they say about paragraph 3 of your letter. And they just don't address it at all. In paragraph 5, they say, we wish to repeat and emphasize our position as articulated to Vishnu a couple of times, with our airport meeting being the latest. Once again, we come on record to state that claims in our system do not justify LOS as indicated in our initial correspondence. Trends of similar kind of admissions emanating from a facility without claims justifying such LOS is alarming and highly unacceptable. Ascot Park has no casualty and is supposed to admit patients for scheduled procedures without exposing schemes to unwarranted SOS. Thereafter, they say, as informed by the foregoing, we have decided to institute a Section 59.3 recovery as per our initial correspondence.
That's
So it strikes me that, you know, you start an investigation, you want particular facts, you get those facts and you don't respond to them. You don't say there's a problem with the facts.
Yeah.
You just assert the conclusion you started with in the first place.
correct. The other point they raised was obviously the issue around the 3 days and longer. I think that's the point that you alluded to exactly now, is that we provided the evidence and they failed to actually engage those doctors. I think the point that I made on the bottom of the slide is that in the city hospital matter, after lengthy appeals, they then came to us and said, let's sit down and look at case by case. This was the first time that they came to us with a clinical person as well, that we could present the case, present the evidence on a case-by-case basis. And during that presentation, there was no evidence found of any fraud on part of the hospital because we were able to present each case. Subsequent to that meeting, they confirmed that they had found no evidence of fraud on the part of the hospital. And unfortunately, in the correspondence that it sent to us when we were engaging in settlement, they indicated that they had made positive findings on 21% of the sample. To date, they have not provided us with the details of that 21%.
What is a positive finding?
So positive finding, my thinking would be is that they've identified some kind of fraud or incorrect basis of charging, because that's my understanding of Section 59. They have to be able to prove that there was some fraudulent act on the part of the hospital, and thus far nothing has been provided.
I understand, but I mean, where does the 21% come from? Because my understanding of the story is that they tell you that there's a problem. You
Correct.
say, well, I can't help you because until you give me the facts.
Correct.
And they give you a sample.
Yeah.
You research each sample, you
Yeah.
give them the answers.
Correct.
So there's no 21% because you've answered the 100%.
So what happened was they gave us a sample of 67 cases, right? And we presented feedback on all 67 of those cases. Of the 67 cases, although they didn't mention it at the meeting, they said 21% of the 67 cases presented, they had findings where they were not happy about.
And then did they tell you which ones of that 67?
They have not provided that to us, despite us requesting for it subsequently.
But during this entire period, your claims are suspended.
That's correct. It's been suspended since November. So Ascot Park was suspended in, so some background, Ascot was suspended in June, and they had indicated that the value they wanted to claw back was 3.9 million. They have clawed back 3.9 million, and they reinstated payments at Ascot Park. I think it was probably from October. Thereafter, we have been getting payments at Ascot, but obviously the 3.9 has been held back. At City Hospital, they've put payments on hold since November last year, and to date, we have received no payments at Ascot Park. Sorry, at City Hospital.
City
City
Hospital.
Hospital, yeah. I think on the percentage as well, if you remember, they initially started with a percentage of 20%, and it was based on their calculation, right? Totally arbitrary in our view, and the 21%, they still haven't presented the evidence to us as to what that 21% is. My understanding is possibly based on 21% of the 67 cases that they reviewed. They haven't presented, so I can't confirm, but we believe it's still arbitrary. I think the important point as well to note is that although they started with 17.3 million, which was their view that they were entitled to claim back, the value that's sitting now, up until probably a few weeks ago, is sitting at 58 million that they've clawed back, that they've held back, and they're still holding.
From Ascot
From
Park.
City. So remember, they stopped paying. So they originally believed they had 17.3 that they wanted to claw back, and they haven't reinstated payments to City Hospital, so we're now sitting with approximately 58 million that's being held back. And,
Well,
these are payments that they have on their system shown as approved, but are in dispute and being held back.
Well, for Ascot, they took 3.9 million rands.
Already, correct, yes.
Yeah. But your other claims are reinstated.
That's correct, yeah.
The 58 million is in relation to your.
City Hospital.
Yeah, okay.
The other point at Ascot, I mentioned this already, was the psychiatric patients being admitted. And I explained the fact that the normal process is psychiatric patients are admitted at City, and only in the odd occasion when beds are not available, they do then get referred to Ascot Park. And I've said here that MedScheme have always been fully aware that Ascot Hospital does not have a psychiatric license, and patients admitted to Ascot are only based on motivations from the doctors. In addition, certain cases being, in certain specific cases where the doctor required additional length of stay, they would motivate for it. And what I've done on this here is I've actually put up, it's a very fine slide, but this is a document that you see there, that this is a document that's on the MedScheme UMS system. You'll see that it's the feedback, it's highlighted there in sort of purple, that say, good day, please note that the facility is not licensed to admit mental health care facility users. Only 2 nights and 3 days can be approved. This is actually on the MedScheme system from the MedScheme case management. So they're fully aware that Ascot does not have a license, and when they grant authorization, this is based on information that's been submitted.
Sorry, I mean, what is the meaning of this? If you have no right to admit a mental patient, why are you admitting them?
So that's the point I tried to make earlier on, is that when there's no beds available and a patient is requiring admission, the psychiatrist would then motivate specifically that he's requesting for authorization for a day or 2 whilst they await transfer to another hospital. So in those specific circumstances only, then they would grant, MedScheme would, by motivation by the psychiatrist, they would grant authorization. This is an example.
But why would they, I understand what you're saying.
Yeah.
But what they are saying
Yeah.
is, please note that you're not licensed.
Correct, but they're saying that is
Therefore,
what,
we will only approve 2
that's
out
correct.
of 3.
Correct.
But if you're not licensed, they should approve none,
Exactly.
or all, if
Yeah.
it's based on clinical
So
support.
So I think just to clarify your point as well is, firstly, that because there's no beds available and the psychiatrists believe that this patient needs to be admitted, they have, on motivation of that specialist, said, okay, we're allowing you to admit. So this is the MedScheme case management team, fully aware that the hospital does not have a psych license. We're giving you temporary authority to admit on the basis that this patient would, in a short space of time, be transferred to a facility that is fully licensed and can accommodate psychiatric patients. So that's the basis. That's why it's a short term. The point I was trying to note here was that MedScheme is fully aware that the hospital does not have a psych license and have granted us authority for those admissions on that basis. Yet MedScheme Forensics are now telling us that you have no license and you're admitting and you're charging for despite you not having a license. I think one of the points that we want to highlight is that one of the psychiatrists that practice at the JMH facilities was unhappy about not being able to admit some patients and treat patients at Ascot Park Hospital. He wrote personally to the Department of Health, who are the regulatory body in terms of licenses, and the DOH department then wrote back to us, and that's a letter 2014 specifying that the Department of Health does not have any objection to Ascot Park Hospital admitting patients.
Where is that?
It's a letter 2014. DOH letter.
No, but you remember that they told you that that letter had lapsed because your license is an annual license.
Correct. So that is
but
why.
we're dealing with things that happened in 2017 now.
Correct. So I think the principle is that from the hospital perspective, we're fully aware that the hospital is not licensed for a psych facility, not licensed for psych beds. And the general rule is all psych patients get admitted at City Hospital. In an odd occasion when beds are not available and the psychiatrist deems a patient requiring admission, then on special motivation, that patient is then admitted to Ascot on the consent of the scheme for a short term until that patient can be transferred to a fully accredited facility.
But I mean, isn't the problem that both you and MedScheme are breaching the law?
But as I said, the principle is that these are emergency admissions, and the priority is to facilitate an emergency care. Just to give some information on the type of patient get admitted. You'd get a patient that is being admitted, has got a medical condition and requiring a psychiatrist to see. This is where patients have comorbidities. And you'd have a psychiatric patient that may require admission into a specific type of facility. So you have a voluntary patient which has got a medical condition and needs to see a psychiatrist. Acute hospitals can manage those patients. You also have patients who are involuntary patients and not in control of themselves and are required to be managed in specific facilities which literally can lock down because and have patients in isolation. Now, the reason the Department of Health said that was that they do not have an objection to having voluntary patients being admitted and treated because patients do have comorbidities. And then the
I would
examples.
understand it if why was the letter not renewed, the 2014 letter from the Department of Health?
We didn't see it necessary at the time because we were not admitting psychiatric patients on a regular basis to Ascot.
I mean, I just wonder what value we should give to your agreement with MedScheme that even though you are acting in breach of the regulations, you should still be paid.
So I think the important point is that I agree that the hospital does not have a psychiatric license, and I explain that these are emergency conditions where the doctor motivates for it. The scheme, I think the point I was trying to make here, the scheme is fully aware, and on that basis have granted us authorization, so they should be paying the account because they've granted the authorization, knowing full well that we don't have the authorization.
So your point is that you cannot have a scheme on a clinical side saying to you, you can admit the patient because it's in their interest, despite whatever the regulations say. And you get the same scheme, but on the forensic side, saying I'm punishing you for an agreement you reached with my clinical people.
Exactly the point. Exactly the point. But the point I was trying to make is the scheme is fully aware, and this is just the evidence that they're telling us, please note that.
But I mean, your point is that it's not that they are aware, it's that they have agreed.
Correct.
So it's not,
That's-
it's
yeah,
not simply being aware. It's that
Yeah.
This is an agreement you've reached with them.
That's correct, yeah.
And would the patient then be discharged after the 2-day, the limited stay, or did it go beyond the
So
prescribed stay?
if the patient, if the authorization has been obtained for 3 days and the bed is available in another facility, that patient would then be transferred. If there's no beds available, or if the admitting doctor believes that he wants to keep that patient in that facility, he would need to then, to remotivate to the scheme, and then the case manager at the scheme would then approve the length of stay for that patient. So this is the case manager, a med scheme case manager, that is providing authority for this.
I mean, if they didn't want to pay you, they should have told you at the beginning that you shouldn't admit patients.
Correct.
Is the med scheme case manager a medical doctor or a psychiatrist?
No, they're not. I think they vary between admin people and nurses. And in cases where they need to refer information, they do escalate. So if they have a particular case where they need to get advice on, they have a panel where they have medical doctors that sit on.
So the decision to approve the admission of a psychiatric payment to a hospital that doesn't have a license for psychiatric patient was being made by non-medical person on the on the medical scheme side.
I wouldn't know. I wouldn't know.
Just tell me, what is the proportion? I mean, I'm trying to work through to understand what to do about
In terms of the value of the number of cases.
What's the proportion?
So I think the sample they had given us were 2 or 3 cases, and Sonny, can you recall how many cases we had in total
Well,
for
I mean,
psych?
we've got 67 cases.
67 were the total. No,
Yeah, that's the total
city was 67 on the city hospital matter. This is the Ascot part of hospital matter. I think we had very, very limited psychiatric patients. I can actually check that and revert to you on that because we did extract that information. We found it strange that they were harping on this particular matter when the number of cases admitted was very, very minimal at Ascot.
It wouldn't have amounted to.
It wouldn't admit it anyway.
Of 3.9 million.
No ways.
Did you calculate how
We
much?
didn't.
it
I think
would
I'm sure
be?
we can get back to you with that information. Yeah.
So you're saying that even if
It's not proportionate.
there's just disproportionality.
Exactly. Yeah. So I think this another point to elaborate is in terms of the authorization process for patients being admitted. The admission process is that a patient would come into the hospital with a referral note, and generally the information is captured on the UMS system, and the scheme has certain conditions. When you capture the information, they give you a limited authorization in terms of length of stay, and then thereafter what would happen is if the doctor is requiring an extension of length of stay, they would have to motivate by our case management to their case management in terms of getting additional length of stay. In addition to that, MedScheme have, I think for longer than last 2 or 3 years, facilitated with the hospital to place their own case management teams at the hospital to be able to look at clinical information on patients that are admitted in the hospital and verify the reasons for admission and the patient care on behalf of MedScheme. And we provided an office for them. They have access to patient records. They walk into the hospital, they go into the facilities, they actually meet patients, they discuss with doctors to extract additional information. So I think this slide just talks around the high care, but I think we've covered that, so I'm not going to elaborate on that one again. I think this is just the last slide is in summary of the points at ASCOT is that we therefore believe that the clawback.
Just tell me, that's 3.9, that was clawed back.
Yeah.
I mean, they wrote you that letter, I think it's FA 13, which they said, listen, we're now tired of talking to you.
Correct.
We're clawing back. What did they do? Did they just withhold pending claims?
So the way this works is that we submit our invoicing via HealthBridge and Health Partners, HealthBridge and MediCredit. And what happens is HealthBridge and MediCredit, it's an electronic medium where we submit via the hospital. It gets into their system, and then it gets onto the MedScheme system. Those accounts are then verified by MedScheme, and they would then pay the accounts. What they've done on the ASCOT matter is they verified payments, verified these accounts have been received and are due for payment. All they've done is they've said is that we are clawing back this amount of 3.9 million rands, although they've approved for payment, but they have not paid that amount.
So they just withheld
Exactly.
future payments from you.
Correct. Yeah.
Now, that is based on their calculation of the 21%.
Now that's based on the 20% of the admissions
well,
that
the
ASCOT.
20%.
20%. This is ASCOT, remember?
Because this is
This is ASCOT. Yeah.
Which, I mean, I was looking for it here to see, because the original sample they gave you, you answered each claim there.
Exactly.
The 20%, where is the evidence of the 20%?
So they have never presented a schedule to say that our claim is 3.9 million rands, and this is the list of cases that we have calculated to say that these claims were fraudulent and we're going to claw back. This 20% is just an arbitrary figure they believe is a number they've worked out, and they haven't explained how they worked that out. It's a number they believe is inappropriate. So I think it's for those reasons that we believe that the clawback by MedScheme Forensics was inappropriate, as they have not presented any evidence of fraud against the hospital, nor any evidence of overcharge. So I think in addition, as you mentioned, they have not presented us with the detailed schedule substantiating their claim.
I just wanted to ask you something else before you go to City. I mean, just on ASCOT. I see the point you're making about the improper application of Section 59 in the way of the investigation. Is there anything here that makes you believe that this has anything to do with racial profiling?
So I think when I present the city hospital matter, you will see that some of the matters in city hospital where doctors that admitted our hospitals also admitted other hospitals, and they have not applied similar rules to those hospitals.
Okay, but not in relation to Ascot.
I think even in relation to Ascot Park, if you look at our patient profile and the doctors that admitted at hospital, we believe that although we didn't initially consider this to be racial profiling, seeing that what's happening now in terms of this Section 59 investigation, we've seen more and more that being the evidence that we're presenting, we see that very similarly we seem to be targeted as a hospital group that is predominantly black-owned and majority black patients and black doctors as well.
But what is your comparator?
What is?
Your comparator, who are you comparing yourself with?
So if you look at, in the Durban precinct, the other hospitals that practice, they are literally the listed groups.
So when you say that we are being targeted for Section 59 investigation, I mean that being targeted means being targeted in relation to X who is not being investigated.
We're not aware of any investigation being carried out at the other hospitals, the listed groups, which are predominantly white-owned. And the other thing is, I think in the city hospital matter, I'll explain to you on the shareholding and why we feel that we're being targeted on that point.
Thank you.
So before you leave Ascot Park, you responded to MedScheme on the 7th of September.
Yeah.
To their letter where they said, we're taking the money. You responded on the 7th of September to make it clear what your position is in relation to those 5 paragraphs or whatever that they came back to you on.
Yeah.
What was their response to you after 7th September?
I think, as is usual with all the correspondence, nothing that we mentioned in our correspondence seemed to be making any sense to them. They just bypassed and said, we made our decision and this is it.
So their response to your 7th September letter is not recorded anywhere. It's just that they then proceeded with the clawback.
Correct, yes. Remember that the clawback had already started from June.
No, I mean in June they didn't claw back, they just refused
Placed
to
on
pay.
hold. Yeah.
They only clawed back later.
I think the other point to make is that the only other hospital that we're aware where there's been a Section 15 or such inquiries by MedScheme is the Capital Hospital in Durban, and where they had a similar challenge in terms of MedScheme forensic investigation. That is also a non-white hospital.
Say that name again.
Capital Hospital. Okay. On the city hospital matter, at the meeting, sorry, I've just been reminded that Midlands Hospital in Pietermaritzburg is also a hospital that was under investigation, and this is also black-owned group. That's the only two that I'm aware of.
Capital is black owned,
And Midlands Medical in Maritzburg.
Midlands is black owned,
Yeah.
and you are also black owned.
Correct, yeah.
And you are the only hospitals from your knowledge that are subjected to Section 59.
Correct.
And specifically, you say that you are not aware of any investigations in relation to what you call the listed groups.
That's correct.
Thank you.
Yeah, on the capital matter, when MedScheme approached the capital group, the matter was referred to the High Court at that time, and shortly before the matter went to court, MedScheme then came through and settled the matter with capital. I don't know the full details of what the settlement was, but I understand the matter was settled. I understand the majority of the claims were paid. On City Hospital, we received correspondence on the 16th of October from Midscheme Forensics expressing concerns around the admitting patterns of 3 doctor directors of JMH. Midscheme stated that these doctors had a higher rate of admission, and in their report they said 70% as compared to the City Hospital ER unit at City Hospital, where the admission rate was 10%. Midscheme stated that the ER unit staff are considered to be independent and was therefore a fair comparison. In addition, Forensic Unit was concerned that these directors were not complying with the ethical guidelines of the Health Professional Council of South Africa to declare their financial interest in the hospital to their patients prior to admission into the JMH facilities. Based on their investigations for the period January 2016 to June 2018 and the methodology used, they were of the opinion that an amount of 17.3 million was considered as being inappropriate and possibly driven by perverse incentives. Sunny, can you just talk through the slide, please?
Okay, so in terms of that letter received, we received 2 annexures with that letter. It was Annexure A and Annexure B. In terms of Annexure A, which we got in the table there, this was what we understand to be the implication that 70% of the admissions were direct admissions by the 3 doctors. What we were able to do was a list of the cases, case authorizations, which we then used our system to pick up the case numbers. And we reviewed the patient files to understand whether this was 70% direct admissions, meaning straight from the specialist into the hospital. On review of the files, we actually, majority of the files, emergency response casualty unit. It's that's the word that they used in their correspondence. Okay, so we found that the 70% was grossly overstated. Majority of the files had referral letters from the GPs in there. So the assumption is that this was a similar conclusion of the GPs, that when they charge cash, you're not picking up the billing information on their side. So we think the 70% was grossly overstated. Then Annexure A was also provided. This listed 201 casualty consults sampled by Midscheme, of which they claimed 21 cases were admissions from the ER unit. Okay, once again, we reviewed these cases and concluded their findings were incorrect. From the 21 cases that they said were direct admissions from the ER unit, we found that it wasn't related, very few cases related to that ER visit. In fact, that ER visit, the admission only happened the following day, meaning that the patient was seen, gone home, and came back into hospital for admission, for whatever reasons may be there. What we then also found is that on our system, because we have a difficulty when a patient comes for the ER visit, when a patient comes for the ER visit, we are allowed to charge a code called 302, which is an emergency consult. That's basically for the use of the nurse in the cubicle for basic IV therapy or procedures. So when a patient gets admitted after visiting the ER unit, on our system we can't bill the 302 code. So for City Hospital, you will never see a ER visit billing code and then an admission billing. So the tariff code, which they refer to as 58004, which is ward accommodation for a medical case. So you would never pick up that. So the list, that's what we found it, but unusual that you give me a list of 302 billing codes and telling me you picked up 21 admissions from this code. So we found that very unusual, and then they used that to conclude that 10% of the casualty visits result in admissions. So it just that we couldn't find the logic in terms of the information they were providing. There. I think that's part of it. And then just to clarify, I think if I can add a little bit more to the capital matter, just that I got a chance to speak.
No, I just want to understand, you know the letter they sent you on the 16th of October?
Yes.
Now, was that the first letter in relation to City? Because the others were in relation to Ascot.
Yes, correct.
That's
From my
correct.
recollection, that's the first letter.
Yes. Now, if you go to 305, then, because there's something I just don't understand, paragraph 6 and 7. says here the admission records of City Hospital revealed that only 21 out of randomly sampled 201 admissions emanated from its ER unit, whilst the vast majority emanated from rooms of directors of JMH, as per paragraph 1 above, and then they say CNHIA. For the same period, a number of med scheme members serviced only 608,871 rands 50 cents of the quantum was paid by med scheme for City Hospital's ER unit. Now, if you look at this paragraph 6, what does this mean? 21 out of a randomly sampled 201 admissions emanate from the ER unit.
So that was a confusion that we also got a bit confused,
see.
because it says admissions. If you selected a sample of admissions, in my mind, these are patients that are admitted into hospital. So you picked up a sample, and off that you picked up 21 cases that came from the ER unit. But on the schedule that we were sent, you sent me a list of my ER unit billing, which was only ER unit visits. It wasn't actually admission. So maybe the word admission or consult in the ER unit was what they were saying, trying to say, on that assumption. But I reviewed the 201 cases, of which they said 21 of those cases resulted in admission. And we could only pick up very few admissions, which were actually subsequent days. So we actually, for the 21 cases, we didn't pick up any information in our system that said that these cases were actually admitted to our facilities.
And then this paragraph 7, for the same period, a number of med schemes members serviced, only 608,000 of the quantum was paid by med scheme. I don't understand this.
I think here they make reference to the fact for the 302 code, they paid 608,000 for that period. So I think the one thing we also want to note is that we actually didn't charge the 302 code when we admitted patients into the hospital via casualty. So there actually was a saving to the scheme.
So is that number then to be compared with paragraph 8?
So paragraph 8 was for those 3 doctors. They've listed their practice numbers, and one is a multi-practice number there as well.
Because paragraph 8 starts off by saying, in comparison, which means what you do, you look at 6 and 7 and you compare with 8.
And here they've picked up the code 58004, which is medical admissions accommodation, and they've come up with that total value for those cases.
Then you do have a response in November directly to this letter.
Yes.
And the membership, the doctors who are directors, the director doctors,
Yes,
whatever you call them.
That's correct. I think
And
Vishnu
their
will
three.
take you through more on that response side of it. I think if I can have the opportunity just to add a little bit more to the capital matter that I was aware of. So the matter did go to High Court and was settled before that. And I think more than 90% of the claims were paid back to Capital. And I think Capital challenged them on the section 59.3. So just to clarify that.
So what do you mean challenged?
Challenged med scheme on the ruling on the section 59.3.
And the High Court said?
Before, my understanding, before it went into High Court, it was paid off.
I see, so this was settled, not decided.
Settled, but more than 90% of that was settled by med scheme.
Anyway, but you are not involved with Capital.
No,
so
just to add the
you
little
just-
bit information.
Yeah, giving us interesting information. All right, thank you. Can you come back then to this
Sure.
issue? City, yeah.
Okay, there's further questions on the responses. Vishnu will take you on that.
No, we had moved on now to your response in November, just to try and understand what exactly was the nature of the complaint.
So in the letter that we sent to them on the 6th of November, it was mainly to give them...
I mean, it is notable, of course, that the 14th of June,
Yeah.
by the time you were informed, they had already decided to withhold payments.
That was on
But
the Ascot matter, yes.
on the Ascot. But in October, when they were dealing with City,
Yeah.
they specifically gave you a right to a hearing. So tell us why we shouldn't withhold payments.
Correct.
That is what is it?
Correct, that's
307?
correct, yeah.
Yeah.
So that's when we responded, and in the letter, we tried to articulate and give them a background in terms of JMH and the history of JMH and the doctor shareholding. In particular, I think, which I've alluded to earlier on, is in terms of the shareholding of the doctors and the breakdown of the shareholders, in particular that the JMH group is no longer strictly a doctor-owned entity, and that it is owned by a new majority shareholder owning 51%, with the balance of the 49% being owned by a company called JMH Doctors SPV. And of that, we have approximately 500 doctors who have historically been involved in the organization. Some of them have now moved on and retired. Majority of them have now retired. And at this stage, we probably have about 15% of those doctors that are still actively in practice. We then expanded in that letter on the 3 doctors that they had, particularly doctor directors that they had particularly referred to. The one being Dr. Chris Jack, and Dr. Chris Jack was only a director for a limited period of time. He practiced from rooms at Duroc Hospital, rooms that belonged to him and that he purchased for himself. And he's a very busy HIV specialist and receives referrals from throughout KZN, and naturally his admission profile for patients would be higher in comparison to somebody else, because he's seeing patients that have come to a stage to him after they've been consulted by other GPs and are quite sick. So naturally his admission patterns would be higher. So that's what we try to allude to them on that one. And the second doctor they mentioned was Dr. R.L. Bula, who practices from, Dr. R.L. Bula is a physician who practices from rooms at City Hospital and from Intibeni Hospital. He's part of a 9-man practice that has rooms at many hospitals in the Durban area, and he's also a very busy practitioner. The third person they mentioned was Dr. Ayaz Vauda, who's a general surgeon. Dr. Vauda, the only practice he runs was his rooms at City Hospital, and he was one of the founding members of City Hospital. And being a surgeon, we explained that generally when patients come to him, they have already, in most cases, been pre-diagnosed as requiring surgical intervention and are being referred on that basis. So all of that information was presented to them, and we advised that these doctors, although they were shareholders, they were practicing at other facilities and they had no perverse incentives to admit at the hospital. In that same letter, we in that same letter also requested for a meeting, at which meeting we could then present in more detail and have a discussion around that with them. A meeting was then scheduled for the 14th of November, I think it was. Sorry, at that meeting, the JMH team comprising Sunny Governor, myself, Dr. Reddy, Dr. Tibete, Dr. Bula, and in fact we invited Dr. Chris Jack and Mr. Vauda to that meeting as well to understand really what their concerns were, and presented again the background in terms of the JMH shareholding and our view that the doctors were not incentivized in any way, and explain the nature of patients that we see. In addition, we did mention to them that most patients that were accessing healthcare services in the central Durban precinct were from the lower and middle income communities who relied on public transport and found the doctors' rooms and hospitals in the area easily accessible due to the proximity around the major bus and taxi routes. Hence the reasons for admission by these doctors to these specific facilities. I think the point that I was making was that one of the doctor directors mentioned in the claim of 16th of October also has rooms and consults from a hospital which belongs to a JSC listed company, which facilitates approximately 5 km from City Hospital. And consequently, most patients consulted at that facility are accordingly admitted at those facilities only. He is coincidentally also a shareholder of that facility, but has not been requested or inquired about whether he's made any financial declaration to his patients in that regard. I think that's the point that I was trying to allude on earlier. At that meeting, Mr. Marabo, who was representing the forensic unit, advised that they had conducted similar investigations into the other hospitals in the group, and unfortunately they had similar patterns where they found that doctors where they had doctor directors or doctor shareholders that were admitting, and their view was that they viewed this as being perverse. Just on the previous slide, the doctor that I mentioned was Dr. R.L. Bula, who was the chairman, at the time, and the hospital of note was the Ntibeni Life Healthcare Hospital. At that meeting, Mr. Marabo advised that they had carried out investigations, or busy with investigations into the other hospitals within the group, and they had found similar patterns without providing any evidence to us. They advised that their intention was for them to place payments on those hospitals on hold as well, and their view was that if they could reach a settlement with City Hospital, they would then place the matter on hold. We at the meeting then asked what would your view be would be the appropriate settlement, and they indicated that the value of 17.3 million was the value that they would consider to be appropriate. At this stage of the meeting, we felt that the approach by Medskim Forensic was actually bordering on extortion, and we requested that we could not make any decisions at the meeting, and would need to obviously caucus in that regard and provide feedback.
Remember that at the beginning, what they wanted was 17 million in their calculations.
Correct.
And so that, suppose it's a discount if they say, well, give us 13.2 million.
No, this is still the 17, and they said if they receive the 17 for City and we settle on that matter, they would consider the matter as being closed for the entire group.
Okay, so the 13 would be for the whole group.
17. They still said the 17, yeah, correct.
But did Medskim report the doctors to the HPCSA? Because what they were alleging was a violation of the HPCSA
rulings.
guidelines.
Correct. We're not aware of them having done that.
Did JMH lay a complaint with the Council for Medical Schemes in relation to this behavior of Medskim?
So unfortunately at the time, in hindsight now we've become aware that that was one of the avenues of our approach, but at the time we obtained legal counsel, and we found that the manner in which Medskim were approaching this required urgent attention, and that's why we decided to go on the High Court route. I think on the issue of the doctor shareholding, just to elaborate, and I mentioned this point in earlier submission, that 51% is now an equity investor, and approximately 15% is now owned by doctors that are practicing. As management and the JMO board viewed this as an attempt to extort a settlement by the forensic unit, a decision was taken to obtain legal advice on the matter, and based on the advice received, as a last resort, proceeded with a claim via the High Court. A copy of the papers have been submitted, in which you've got. We were then approached, I think whilst we were waiting the High Court matter, we were waiting for the date for the matter to be heard. We received a call from Paul Madlane, who is the general manager of Medskim Forensics. I think something was sometime in, was it June sometime? 26th of June. Our chairman, Dr. Bula, received a call from Paul Madlane, says that could we...
This year?
This year, yes. Could we perhaps discuss this matter and try and resolve the matter out of court? I think that's always been our intention, that we wanted to resolve the matter, and unfortunately because we weren't presented with adequate evidence, we could not settle the matter. And He then requested we facilitate a meeting. We were only too happy to facilitate. We consulted with counsel and we advised that to engage with them on a without prejudice basis, and then we then facilitated a video conference which took place a few days later. Right? I think this is the slides here just show the background. In terms, we had that video conference. At the video conference, MedScheme again reiterated their concerns that we had doctors who were shareholders and directors and were admitting into the hospital, and they believe, based on the investigation, that the doctors' admission ratios were disproportionately high, again without providing evidence, and the length of stay was inappropriate, and they would like to present this evidence to us so that we could then resolve the matter. We said we're quite happy to engage with you and sit down with you and discuss the matter. So we then agreed that they would send us a sample of cases that they had identified as being inappropriate admissions. They then circulated 2 schedules making up 67 cases to us, which we went through on a case-by-case basis between our group nursing services manager, and extracted the information from the patient files, and we then prepared a report which we presented to them on a case-by-case basis on the 16th, I think the 15th and 16th of August. At that meeting, we requested that they arrange to have present from their side a medical practitioner who could understand the rationale in terms of the medical cases, because thus far I had been dealing with McDonald and he's not a medical person, and myself being not a medical person, we insisted that we have that. So they facilitated for Gregory Pratt to be present, and from our side we had our group nursing services manager that presented. We also had Dr. Bula was there, and Dr. Tabete and Dr. Tesire that presented on a case-by-cases each of those matters. At the meeting, they indicated that they had found no indication of fraud on the part of the hospital, and we're happy that we had presented the information. And they also indicated that there were obviously no incorrect charges on the part of the hospital, because there was no evidence presented on incorrect charges. They did indicate at the meeting that...
Well, what did their doctor, what was the position of the doctor that...
He went through case by case, and I think on certain cases...
This is the doctor for MedScheme.
For MedScheme, Gregory Pratt. He went through case by case, and in certain cases, the information that was presented by the nursing services manager obviously is with limited knowledge. He then interrogated and asked further questions, and the doctors that represented JMS that were present at the time gave further input on those matters, and were able to present and explain those matters. Some of those matters, unfortunately, were not relating to the doctors in question that were listed, being Dr. Chris Jack, Dr. Vauda, and Dr. Bula, and were relating to other doctors who were not present at the meeting, and we could not obviously present a response from those doctors because they were not invited to the meeting.
You just tell me, I mean, if you just take you back to your exchanges with the MedScheme around the settlement at page 413, my understanding is that you had a meeting sometime in November,
Yeah.
where the issue of the settlement was raised. But you asked for time to caucus, and your view was that it was extortion. But on the 30th of November, he then writes to you and says the following. He says, "We note with disappointment that more than 10 working days have lapsed since we had a formal interaction, and up to this end, we still have no settlement proposal from the facility.
Yeah.
As informed by the foregoing, we wish to advise as follows. We are in a position of strong belief that we afforded the facility more than ample time to consider the matter. We consider close of business today as a due date for any submission. Should we fail to receive same, we will proceed to finalize the matter as clearly laid out during our meeting." I mean, it seems to me that there is pressure being put, not so much to establish the facts, but to put money on the table.
Exactly, that's the point. I think a point to note as well is that at this stage they had not provided us any specific cases or those doctors in question to say that these are the cases where we're not happy about this particular clinical call on the doctor and we believe that the admission was inappropriate. There was no detail shared at that time. The 67 cases that they shared only came to us now in August, July, August.
So there wasn't a figure, or was there a figure,
So the
That
17
from
the
their side?
So the 17.3 million was based on an extrapolation of what they believed of 20% of the cases admitted by those doctors was the tariff portion of the revenue, which they believe was inappropriate. So their view was that 17.3 million
After all the explanations that you provided, they
No,
will
th-
still
this-
remain.
this 17.3 was the point that was from their first letter dated October. And that's the figure
So
they
none of
proposed.
none of the responses that you provided in relation to the specific concerns
Made
that
any
they
difference.
raised, did they take?
Acknowledge, correct. And remember that this discussion of the 17.3 started before they even presented any evidence of cases where they found that there was inappropriate or fraudulent admissions. Okay, so I think this slide kind of talks through the discussions on that 67 cases that we had. And I think the one point to note that it did emerge during this discussion that some of the queries that they had raised did result from a lack of adequate information on the part of JMH, where our case management team had not provided adequate coding information or time-use information to the scheme. So unfortunately, we found that we have to acknowledge we do have some issues around resources and ability of the case management in terms of proper coding of the cases where the scheme can see the accurate clinical position of the patient. But at no point did the lack of that information make any difference, because those patients were valid admissions and were not fraudulent admissions. So in the 67 cases they presented, we were able to then articulate them around the background on that. So that was one of the things that came up at that meeting. Medscheme at the meeting advised that they had some concerns around the adequacy of the admission criteria applied from the outpatient department. Now this, again, after having gone through all of the cases, originally they said that they believed that the outpatient department, being an independent organization, had probably more appropriate admission principles. And when they went through the files, they came back and said they had some concerns that these doctors probably didn't have adequate admission criteria before patients were being admitted, and that in certain cases they found that patients were being admitted perhaps too soon and should have been diagnosed properly before as an outpatient before being admitted. Now, one of the concerns that the outpatient department doctors have is when patients come to them, particularly in the evenings, is that a patient comes to you coming from an outlying area, reasonably unstable, and presenting with conditions that, in your opinion at the time as a doctor, that you think you need to admit the patient. He obviously makes a clinical call at the time and admits the patient. The scheme is concerned that the patient is being admitted and some diagnostics only being done on the next day. Now, unfortunately, looking at a case in hindsight is always, it's fair and well to look at something in hindsight and said that the doctor could have made a call and this could have been done as an outpatient admission. But when the doctor is there and he's seeing the patient at that time, it's his call, and there's always going to be a judgmental difference between one doctor and the other as to whether the patient should have been admitted or not. And that's something, unfortunately, none of us can really explain and make a categorical decision on. So they expressed concerns on those, and they said that in lieu of that, they believe there have been some wasted costs on the part of the scheme, and that they would request that the hospital consider that and make a proposal of settlement to the scheme. At this particular stage, they had not presented to us any number or list of cases that they believed or what quantum they believed would be an appropriate number that has been wasted in terms of cost on their behalf.
Take you back to the correspondence
Yeah.
from Medscheme. You see, page 429. Look at what they said to, I think at that point you had appointed Minal Soni.
Yeah.
And this is how they respond to her. In paragraph 6, it says, should JMH not wish to cooperate with the audit on behalf of medical schemes, we suggest that they run a cash facility and charge members upfront. It will then be the members' duty to prove the validity of the claim. Now, I mean, if one reads this, you could get the impression that you refuse to cooperate with the investigation.
So I think, for me, I think this has generally been the tone that's been carried on, even from the previous point that you raised, is that for them it was that we made you an offer to settle this matter, come up with a settlement, even despite having proven to us that these are the cases that we found as inappropriate. We want you to settle, failing which we're now going to stop authorizations to the hospital, and you would now be treated as a cash facility, and the patients can be pay you cash and then claim from the scheme.
And in the last paragraph, where it says, we find the tone and attitude of your correspondent unfortunate, as your client previously committed in writing to providing full cooperation in order to bring finality to the matter. Now, when they say full cooperation, there are two issues at stake. The one is the investigation, which you've been providing them with the facts.
Yeah.
The other cooperation is put the money on the table.
And so if you look at all of my correspondence, even on the Ascot matter, I've always been reconciliatory and said, we want to cooperate, we've had a good relationship with the schemes, and what you bring to us is something that we've not been aware of, and we want to engage with you and to understand what your concerns are. So one, we can put corrective measures in place, and if it's to do with something with the doctor, where the doctor is off, out of bounds or whatever it is, we can engage those doctors and explain to them what their concerns are. So we've never been non-cooperative.
And then it says, it would be advisable not to prejudice your client with poor legal advice. Poor, ill-advised legal advice. And then it says, this is a matter of ethical and clinical best practice, not to be confused with the legalese around statutory interpretation. But if you look at paragraph 2, they say this matter is about section 59(3) of the Act. Now they say, no, it's not actually about the law, it's about
We agree with that.
clinical best practice.
Yeah.
Now, I mean, it seems to me you can comment on this if there's, on the one hand, it's the investigation, which is, I need the facts. You are giving them the facts, and
Yeah.
they obviously don't respond to the last set of the facts you gave here, and they say, well, you're not cooperating.
So I think, on the city hospital matter, they had presented us some broad-based facts on that letter. There were no specific details as to, on a case-by-case basis, that these are the cases that we find as being inappropriate, like they've done in the 67 cases eventually, and which we've addressed. At this stage, there was no information presented. It was just sort of a generalized statement they made on what they believed were inappropriate admissions. I think our view was that we've been complying with all of their requests in terms of providing information, and the view is that we've complied with all of that. They've now shifted the goalpost to something else, which is relating to maybe the HPCA regulation or whatever it is. We don't understand the rationale, but they seem to be shifting the goalpost all the time, because even in the correspondence that we send to them, when we respond, they go back to the same points and respond on the same points without even considering the evidence that's been provided.
You did make an offer of settlement at some point.
I think when they presented the 17.3, we believe that 17.3 was to some extent bordering on extortion. When they then had the meeting on the 15th and 16th
Why
of
to some extent bordering on extortion? If you didn't, you disputed
Okay,
that
so-
you owed any amount of the 17.3,
So I would think, if they had proved evidence, they had provided evidence that there's fraudulent claims, then we would obviously be engaging with them. At that stage, there was no evidence. So and the reason I'm saying to some extent is because I've got no evidence to say it's extortion. My view is it's extortion.
I mean, I suppose the question is, why are you considering settling a case that you believe? I mean, I suppose you say you just want to get them off your back.
Exactly. I think if you look at the way this matter has been handled, now for an organization like ourselves, starting with a claim of what they said was 17.3, they're now holding almost 60 million rand back. Surely this is going to have an impact on my business. And I think seeing the way that this matter has been approached, we've incurred, I think, lots of management time trying to address the matter. The doctors within the facility, because they've been aware that this hospital is under investigation, they to some extent are now of the view that perhaps we should not be admitting at these hospitals because they are under investigation, and they could be compromised themselves.
And what was the amount of the settlement proposal that you made?
So in terms of the negotiations on the settlement, this only came through after the meeting on the 15th and 16th, where the scheme said that, take into consideration the fact that the outpatient department may have some admission patterns that may be inappropriate and they resulting in loss to the scheme, you put a proposal as to what you believe would compensate the scheme for these inappropriate admissions. So we looked at it and take into consideration the fact that in their letter they mentioned that there was 600,000 paid to the outpatient department. We looked at it and said, as an arbitrary amount, because we've already incurred so much of cost in this matter, and strictly on a without prejudice, without admitting liability, on a commercial basis, we offered 500,000. That was the initial offer that we made.
And that was in respect, but the whole series of concerns around the outpatient department was something that only came about this year.
Exactly. If you remember in the original letter they said that they believed that the outpatient department was an appropriate independent
Yes.
structure, that the admission numbers were appropriate. And here they contradict themselves by saying that we have concerns around your outpatient department because we find this, this, and this is wrong.
So you say 500,000 was the
500,000
initial offer?
was
Did
the
it
initial
increase?
offer. Was the initial offer. They then wrote to us. Let me get through that page. Sorry, I blocked it out on the screen because I thought it was maybe inappropriate to have it. Correct, yeah. So I think the way we presented this was that the 500,000 was made effectively as a discount, not in acknowledgement that we're writing of specific claims. We said that in lieu of settling the matter, we would offer you a discount of 500,000. So even in the subsequent correspondence, we've also said it's a discount. So the forensic unit then wrote back to us declining that original offer of 500,000 and said that they had made positive forensic findings on 21% of the files, of the 67 files that they had reviewed. Now remember, prior to this settlement proposals, they had not told us about positive forensic findings. It's only after we made the settlement they said that despite us having reviewed those files, we still made 21% positive forensic findings, and no details were shared. They then came up with a proposal of 5.8 million as a full and final settlement for City Hospital. And again, yeah. So I think this was made on that, in the correspondence you see that it was made on the basis that if we can not able to settle, they would then proceed with stopping authorizations to the hospital, and we would then be placed on a cash basis. If we were not willing to accept that 5.8, yeah. And again, at this stage, the scheme had not shared the case-specific information of that 21% that they alleged to have had positive forensic findings on. In an attempt to resolve the matter, we then went back to them, and particularly with the threat that they had carried out similar investigations at the balance of the group, we said that, again, as a nuisance factor, that we would rather move on with the matter, and we proposed an amount of 3 million rands as a full and final settlement to date, including all cases that they had, or claims that they alleged to have up to end of August. They then wrote back to us on the 13th saying that their view was that the 3 million rands did not compensate them for the losses which they believed they incurred, and that they would proceed with the legal process, and we would be hearing from the attorneys of reference on each of the schemes.
What does that mean, that the matter will continue?
So-
That
so
they
if
will
it-
institute a claim against you because they've already withheld the payments? So
Exactly.
there's no
So-
claim for them to institute.
So my understanding is that they're going to continue holding back payments, right, until the matter is settled in court.
Until your own application to court is resolved.
Correct. So remember that
They had recovered the money by this time, haven't they? What,
Remember,
the
the original
amount
claim-
that they,
exactly. Their claim was 17.3 million rand. They're now sitting with 58 million rand, which they've approved for payment, and is sitting on their system as having been approved, but they have not paid. Right? In their correspondence to us, they said that they still have concerns about certain specific about admission patterns, and they still haven't presented that evidence to us, and that's why they're alleging to hold, because there's claims subsequent to May last year that they believe they're entitled to.
so they're new issues,
New
in
issues.
other words.
But even so, I mean, in the 67 cases that they presented to us as evidence, only 21% of those they believe they still have a claim for. They haven't shared that with us, and we don't believe it's justifiable. But they're saying that subsequent to that, they still have claims. But they're holding back now 3.5 times the value of that 17 million, which is totally ludicrous.
Can you just tell me something else? What is the, I mean, you explained at the beginning that you are a black group, but I mean, if you are owed 58 million rands,
Yeah.
I mean, what is the impact of that on your operations?
So fortunately, mid-scheme, in terms of the proportion of our business, it's certainly probably 10 to 15%. 10 to 15% of our business. We've actually had to go on to get overdraft facilities, to utilize overdraft facilities for that, and we've explained that to them as well. We've incurred additional cost from that time to now, approximately almost 2.8 million rands in overdraft fees.
Have any other Section 59 investigations been conducted in relation to JMH?
So
Any other schemes, by any other scheme, not med
No.
scheme?
No, there is no such thing. I think just a point to make as well, in terms of the amount of money they're holding, 58 million, rand, this is going to be extremely prejudicial. We do have overdraft facilities that we can get, but we're going to get to a ceiling at some point in time, and it's going to impact on our business. I think the second point is that because of this investigation, doctors are now afraid to admit to this facility because they believe that we are in an investigation, and the schemes will investigate those doctors that are now practicing at these facilities. So they're now actually afraid of admitting at the facility. And that, to effect, is also affecting our business.
The doctors.
Exactly.
And the patients would have to pay upfront.
So
on
the way it is
the
now,
med scheme members.
so what's happening currently is that, remember, we've continued on risk, on relationship in the interest of patient care with med scheme to admit their members. They continue to give us authorization, we continue to treat their patients, and we continue to submit bills. They continue verifying those bills and agreeing that those payments are due to us, but they're withholding their payment.
So you don't ask the members for an
We
upfront
haven't done
payment
that.
in respect of meds?
I think we do have an entitlement that we could actually go to those members and claim from those members directly, but we've chosen not to, because we know that most of those members do not have funds available to pay.
Yes, I do want you to expand on that, because you see, the inquiry, I mean, has got both the racial dimension, but when you say most of these members are unable to pay, what does that mean?
So, as I mentioned earlier on, is the patients that we see are from lower and middle income communities. Majority of them can barely afford their medical aid. And when they have medical aid, the assumption is that when they get sick and they need to get admitted to a hospital, that their medical aid would foot the bill. In our circumstances, we've applied for authorization, they've come to the doctor, we've applied for authorization, we've treated those patients, they've been well, they've been discharged, we've submitted our bill in terms of the normal process that we'll be required to submit, they've been validated by the scheme, they've been placed on the system of the med scheme to say these claims have been validated and due for payment, but yet they have not paid. These members that we're referring to, if we have to go for them, their bills will range from anything for one day, which could be 2,000 or 3,000, to 30 or 40,000 or 100,000. Where are these patients going to get that money? For one, if we decide to sue them, they're going to have to now get an attorney to represent them. They're not able to do that. These are patients that are barely affording their daily income, their daily expenses. I think the other important point to note is that although these claims have been verified on the medical aid, on the MedScheme system, to say they've been verified, in terms of Regulation 6, they have 30 days within which to dispute the claim. We've submitted our claim, as I said, in terms of the normal process via the EDI system. They've been validated by MedScheme, and they've been put on the system as being validated and due for payment. Had they had any concerns about those claims, they should, within 30 days, come back to us, which they do sometimes, that we believe that you've overcharged for this, or you've charged incorrectly for that, and they do come back. But in these cases, they have not followed that process. Even on the 58 million that they're holding back, there are certain cases where we've submitted our bill, and on certain items on those specific cases, they have chosen not to pay us because they've, in terms of the rules, those amounts may not be payable, not be chargeable or whatever, and they've said that this is not chargeable. And they would normally say that it's not chargeable in the rules and this is the code. But in these circumstances, they have approved the payment and the monies are being held back.
So, is it right to characterize it as, I mean, it's a blanket approach now to JMH to say claims that will come in will just not be, it's not that they're not approving the admissions or the treatment, but claims will not be paid.
That's correct. So although they're giving us authorization, they're validating the claim when we submit the account, and it's shown on their system as being approved for payment, they're just not making the payment. So I think in terms of the review of the files, they presented the 67 cases, and we've presented the evidence. They then came back and said we've got 21% of cases where we found anomalies. They have refused to give us any further details on those 21 cases, and they said that we will go to court and present effectively case by case. That's what they've refused to give us any further evidence of those matters where they believe that they have anomalies.
Just tell me, when this was happening prior to the announcement of this panel, why did you not complain to the CMS?
Unfortunately, at the time, I wasn't aware that that was an option available to us. And I think, as I said earlier, is that because of the manner in which this was being approached, we believe that, and from the fact that we had heard that the capital matter had eventually to go to court before MedScheme Forensics release payment, and we thought that that was the only way of getting access to our payments. We did make an application on an urgent basis to the Durban High Court. To the Durban High Court.
Oh, I see.
Yeah.
Can you, if you're able to, can you tell us what your understanding, the interpretation of Section 59(3) is when it comes to the amount that is to be paid to the scheme? Is it correct? Would it not be correct to say that it must be a quantified specific amount?
That's correct. That's my understanding. And thus far, MedScheme have not provided any evidence. I think also they have to provide evidence of fraud on the part of fraud or claims where the hospital is not entitled to. And so far, all the claims that we've been submitted, as I said, have been verified on the system. They have not told us that you're not entitled to this particular amount. In cases where they have told us, they've obviously not paid us for those amounts.
But for the claims that they're withholding now,
Yeah.
where they approve it and all of that, why do they say you're not entitled to the payment?
I don't know.
They can only withhold it if you're not entitled.
Exactly, I don't know. As I said, we Those cases which we claim for are patients that come to us, we get authorization, accounts are submitted, they're validated, and they should be paid.
I mean,
It's
is
for
it fair
services
that
then.
to say that from your perspective, the only reason these are being withheld is not because they are not due, it's to put pressure on you to settle.
That is my view. That is my view. In addition, they have not substantiated any loss that they've incurred to us.
Yes, but your earlier point was that if they had, they would only be entitled to the extent of that loss.
Correct.
All right. All right, thank you. Do you have anything else to add? I mean, I know we haven't quite allowed you to speak freely, but you know, we had
I think-
asked the things that concerned us.
Yeah, I think from our side, we've always been committed to resolve this matter, and unfortunately, I think the manner in which MedScheme have carried this is totally unacceptable, and we would like our payments to be made as soon as possible.
Thank you. I want to thank you for coming and presenting and for preparing for this work. We will be in contact with you for further information, and we will be sending correspondence. I have no doubt that you will continue cooperating.
Certainly.
Thank you. The
Thank you.
inquiry is adjourned for the day. We will continue tomorrow at 10 o'clock.